Welcome, everyone. It is my joy and honor to welcome you all to Cultivating a Trauma-Informed Approach to Healthcare. My name is Aria Geyser. I am the Liberation and Culture Specialist with NJ CASA. I'm so excited about this panel. You know, when the topics were shared with us, immediately I gravitated to this one because I find healthcare, public health, such a dynamic and cross-cutting and really holistic field. You know, when we think of health, sometimes it can be tempting to just think of like the actual going to a healthcare facility and that experience, but we don't think about all the ways the systems of oppression and the social dynamics that we live in and policies actually impact our health, both physical and mental. So yeah, just really quickly for an image description of myself, y'all are gonna get fed up of hearing me say this quicker than I'm gonna get fed up of saying it, but I am a very beautiful, Afro-Caribbean woman. Right now, I am wearing a hijab that is a black and white keffiyeh pattern, which is a cultural Palestinian fabric. It is a symbol of resistance and liberation for the Palestinian people. And I have a fairer complexion, lightly melanated, but still very black to the core. And yeah, I will now go on to introduce the amazing panelists that we have here. I'm so excited to just learn from them and, just soak up all of the wisdom and hear all of the perspectives that they bring and all the skills and insights. So first up, we have Benny del Castillo. Benny del Castillo is a Latinx immigrant and Spanish-speaking woman living in Washington, D.C. She worked as a bilingual case manager in a domestic violence safe house in New Jersey before moving to DC in 2014 to work at the Network for Victim Recovery of DC, NVRDC, as a bilingual advocate. Benny is a practicing trauma therapist, primarily working with sexual assault survivors, and also the engagement manager at NVRDC. Thank you so much for being with us here today, Benny. I'll turn it over to you just for an intro and an image description.
Thanks so much, Aria. Hello, everyone. Like Aria said, my name is Benny. My pronouns are she or they. I'm cool with either of them. For an image description, I am a Latinx woman, some melanin in me, yes, and I'm wearing a floral top. The base is pink with just some purple flowers, and you can also see my book, my bookcase full of books in the background.
Wonderful. Thank you so much. I love the flower theme, getting ready for spring, getting in the vibes for that. Nice. All right. Next up, we have Linda Sloan Locke. Linda has a career-long commitment to health equity, social and reproductive justice, the intersection of health and mental health, and the impact of violence on health. She practiced midwifery for over 40 years, y'all, in a variety of settings, and is currently a consultant and therapist. She is the founder and executive director of the New Jersey Health Cares about domestic and sexual violence collaborative, which envisions and supports a healthcare culture in New Jersey where all healthcare providers recognize the prevalence and health effects of domestic and sexual violence and practice trauma-informed care. Linda, I'm gonna turn it over to you real quick. Get the intro and the image description.
Thank you so much, and thank you for having me today. Again, I'm Linda Sloan Locke. I am a light-skinned Black woman with short, curly hair that is now a mixture of reddish brown and gray. I am wearing brown glasses and a dark green turtleneck. And in the background, I have a wire sculpture with beautiful, autumn colored leaves on it. And again, thank you so much for having me. I'm really excited to participate today.
Thank you, Linda. We're so happy to have you. All right, y'all. So last but certainly not least, we have Simone Snyder. Simone is a training coordinator at the Center on Research for Ending Violence at Rutgers. She is also the co-executive director of Global Foundations for Girls. She is a co-adjunct faculty member at both Rutgers University and Monmouth University. She has worked as a doula, dating violence prevention educator, and hospital domestic violence response team DVRT coordinator. She has spent the last 15 plus years training on topics related to reproductive justice, maternal health, and gender-based violence. Welcome, Simone.
Thank you. So my name is Simone Snyder, she, her pronouns. I'm so honored and excited to be here. It's all I've been thinking about for months because I'm so excited to have this conversation and to be in the presence of these amazing people doing amazing work. In terms of a description, I'm a multi-ethnic, also of Caribbean descent woman with brown long hair. I have a green V-neck sweater on, and I also have a bookshelf of books behind me and plants all around to try to calm my nerves. I'm just really excited to be here.
All right, y'all. The first question that I have, and this is directed to everyone, so feel free to jump in. As we know, survivors of gender-based violence seeking healthcare can unfortunately be re-traumatized during this process. How can provider-patient power dynamics within the healthcare system be addressed, but also dismantled to foster a system where survivors' bodily autonomy is not only centered, but also respected and fully actualized?
So if I can start, so there's a couple of things that come to mind for me that providers can really do to work in this, to improve our relationships with our patients and clients in this area. And one is to commit to the principles of person-centered care, which some of the core principles are respect for people's values and preferences and express needs, responding to their need for people's need for education, information, making sure folks have access to care by removing barriers, providing emotional support to relieve fear and anxiety that people have when they're presenting in healthcare very often, involving people's families and friends, their tribe, their support system when they come in for care, and providing physical comfort. And the other one is a commitment to shared decision-making, because we have this system that's been developed that's really very autocratic in the way it was developed, with this hierarchy of the provider, being a gatekeeper for healthcare, for people to receive healthcare. In shared decision-making, the two people engaged in that partnership are equal partners, right? So that the patient or the person seeking care is acknowledged as an expert in their own lives and their own bodies. And the provider is the expert in their area of care. So they both share their expertise with each other as equals, rather than having this hierarchy. And using that model, we could maybe begin to break down this hierarchy that interferes with really delivering the best care.
I can add to that a little bit too. So a lot of what you're saying resonates with me. And I think also, at the most basic level, we sort of need to change the way, like we need to start from scratch, right? And change the way we approach medical education in this country. And so I think also of the implicit and the explicit work, right? So yes, we need to improve education. We need to really sort of embed in our medical education systems, what survivor-centered care is, what trauma-informed care is. But I also think that what we need to do is look critically at the power dynamics and hierarchy that's embedded in these systems, right? And so how it's set up between medical students, residents, doctors, nurses, midwives, community health workers. And for me, I feel like we can't even begin to really address and dismantle the power dynamics between providers and patients if that is still so ingrained in the medical systems and the systems that the survivors are walking into. I think we need to build in medical racism in the curriculum, trauma-informed care, really understanding like culturally specific work and gender responsive sensitivity, addressing, racism and discrimination head on, but we really need to explore sort of this power and this hierarchical system, right? Because if we teach all of these things, but then that's not sort of modeled in how people treat each other in the system and how they treat, staff and anybody engaging in the medical industrial complex, then I don't really see much changing if it's not sort of played out in the behavior as well. I think we'll get much more into this, but I think there's a lot more relationship building and communication that needs to happen. And I think in terms of bodily autonomy, I think we have to, outside of medical education, we need to teach that early and often in schools to our youth. One of my favorite stories, my best friend's daughter, she was about 12 at the time. And obviously, like, I have conversations with all the children around me about these types of topics. And she called me one day, not really so happy with me, but they were in the doctor's office. And I don't know what they were, it was probably like a shot or something. And she was like, I don't want to do it. And she just kept saying, my body, my choice, my body, my choice. And so this is a funny example. And I love this story because, at the end of the day, she probably ended up getting whatever procedure they were recommending. But that doctor had to take a minute to like sit and talk to this 12-year-old girl about what it was he was suggesting. And she was like involved in this decision-making process about something that was about to happen to her body just because she, had that language to say. And so I think part of it is, better equipping and educating our healthcare professionals, but also starting young with our youth that are going to be engaging in these environments in the future.
And thank you both. And I would love to just add a little bit here and to kind of dive into what Simone was saying and bringing up is we need this recognition that historically there is no system in the United States that was built specifically with marginalized communities in mind. If anything, right, it was the complete opposite. It was like, let's build systems that further marginalizes and oppresses folks. And the reason I bring this up and say it so bluntly is without that acknowledgement, both, as any human on earth, but really as like any person in the field working with survivors, without that acknowledgement in ourselves, without that acknowledgement in the room, without that acknowledgement as I leave the room and am also a human just in the society, we won't get anywhere. Right. And I think it's doing exactly that. We need to do our work as like, okay, I'm a human being living in this country, living in this society. What do I need to constantly learn and acknowledge for myself? Because that influences how I show up in front of a survivor, in front of a patient, in front of a client. And it just does. And what conversations, what language am I using? Right. Like, especially within the healthcare system, the medical system, the language we use for people is so dehumanizing. Even just the concept of, for example, the word non-compliant, like a non-compliant patient or client, right? Like, what are you saying about a human being? They're just not consenting to something which is based on bodily autonomy in their lives, right? And just like changing and shifting our language, shifting our viewpoints. Like Linda was saying, like shifting the fact of who do we consider an expert? I actually don't even really love that word. It's like, what level does it make you an expert on anything? Like we're constantly learning. The only expert I view is like, you're the expert of your life. And also when you're coming into a room with me or a space with me, like me really taking the time to be like, okay, you're bringing a lot with you and let's unpack that together. So I really think uplifting that is really, really crucial because otherwise we're just kind of replicating these systems in every interaction. And I think especially for survivors of violence, whether that's sexual violence or any other kind of trauma, everything is really important, right? Because like sexual violence and most trauma, like 99% of that is experienced within relationships. Even if it is a stranger, it is a relationship of like human being to human being, right? And so every person has a role to build a relationship, even if it's for 15 minutes that they're in the office with you, that is a healing one that literally teaches their brain like, hey, this was so different than any other experience. And that is so powerful. So that's what I hope to come out of any interaction people have.
And just to add to that, that's so beautifully said. We have to acknowledge that the medical care system that we have right now is really not built on healing. It is an illness treating model, not a healing model. And until we make that shift to really supporting healing, we're really not going to be able to do justice to the people that we want to serve.
There's so much that I want to just ask each of y'all about in terms of your responses and what you said, in the interest of trying to stick somewhat to the time that we've been given. I just wanted to highlight something, Benny, you were talking about the fact that the language that's often used is, there's things like non-compliant. And then they'll say things like, well, this person doesn't consent, or they don't trust us. We have to go into the communities and work to rebuild trust. And it's like, that makes an assumption that trust was once there and then something happened. Whereas, as y'all all very well and explicitly, suggested, is that these systems were created with the exploitation of people and for the exclusion of certain people. So it's very, very much functioning, one, as it was intended to, but continuing these legacies of harms. And, Linda, you talked about this transitioning more to a healing model. And I would love to learn more about how we actualize that. How do we actually take these principles and these ideas that we're talking about and transition them from a more linguistic or abstract space into something actionable and practical? So if at any point you would like to share a little bit more about that, I'm all ears. I would love to hear. But also, I don't want to put you too much on the spot, because I do have another question for you. So this one's a bit of a mouthful. Medical racism, as Simone was talking about, right? And the stereotypes that have been responsible for the torture and murder of innumerable Black people as the medical and surgical industry in this country was being developed. We know of J. Marion Sims, this physician who is known as the father of gynecology. It's almost offensive, the irony in that, right? It's so offensive. But for folks who may not know, he was a surgeon, and he kept these horrific records of how he would perform surgery on enslaved Black women, very often without anesthesia, because at the time it was thought that Black people were tougher, could endure pain better, and also had less nerves, and I think any reasonable person could recognize what a heinous fallacy this is. And even though it's something that began during slavery, it has still persisted. This idea has still persisted to the modern day. A 2016 study, so we're talking about not that long ago, of medical professionals showed that 40% still believe that Black skin was actually thicker than white skin. Also for centuries, stereotypes of promiscuous or hypersexual or strong Black women have resulted in increased instances of sexual violence, dehumanization, and just Black women not being protected or believed. So what I'm curious to know about is, what other pervasive falsehoods and misconceptions do we see that, work to the detriment of communities of color and negatively impact their health? How do healthcare systems become more accountable for this legacy of harm caused to patients, particularly those who have been minoritized and marginalized?
So we only have 10 minutes, right? So, so that's like a book, right? Or several books that have been written about this. And you identified several things. I also want to identify one that many people are familiar with, the Tuskegee experiment, where Black men were observed to observe the natural progression of syphilis. And what a lot of people don't realize is this went on for 40 years, from 1932 to 1972. Again, not hundreds of years ago. It was only, the study was by the U.S. Public Health Service, and it was only stopped because of a reporter identified what was going on, and then it went up and it became public, and it was stopped. It probably would have gone on longer if somebody from the outside hadn't identified that. So that there are many, many, many examples of medical racism and sexism and oppression that have really been woven into the fabric of our medical system. And I think there's two things that kind of they're based on. One is this idea of this biologic difference of race, which we know is a fallacy, right? We know that that we're all about 99.9% identical in genetic makeup. But back in the 1800s, these older white men made up these categories of race based on what people looked like externally. And this idea that there is this biological difference and then this othering of people, right? So that this idea that people are going to react differently, and people are going to carry diseases because they're biologically different. And again, it's not, Simone talked about the medical education system. In 2011, there was a medical text that was used for many people studying for like board exams. And in his textbook, it identified 30 different diseases that were associated with African ancestry. So this is really, this kind of thing is really pervasive, and it still goes on today, talking about medical testing. So in 2020, the New England Journal of Medicine identified 13 different medical tests. Now we're talking about medical tests for important things like heart failure, kidney function, that have race-based adjustments. These algorithms include race as a factor when they're calculating the results of these tests. And in every case, these corrections result in potential harm for Black, Brown, Latinx, Asian, and Native people. So the way that this idea of biologic difference has been embedded in the whole medical educational system and the medical care system continues to be harmful to us. And then the other one that I think is really has played a big role is this idea of the default human being white and male. And so that if you're outside of that, you're abnormal. This idea that people will present the same way, their signs and symptoms will be the same as this default human, right? And so it just builds into this idea that that is the one way that people will be. And so one example of how this has played out recently is in COVID, when the incidents with the pulse oximeters, which you may be familiar with. Simone's nodding. So pulse oximeters are those little clips that they put on your finger, right, to see that how well your blood is oxygenated. And they've been used for a long time in surgery, in hospitals, but they were really widely used during COVID to see how severe people's disease was and whether or not you needed to have, more intensive care. Lo and behold, it was discovered that it came to light, I'll put it that way, that many of these pulse oximeters had been developed to be used with white skin. And so if a person did not have white skin, they were not as accurate, which meant that the calibration was not sensitive to melanated skin. So there were inaccuracies in estimating the oxygen saturation, and it underestimated severe disease in people with melanated skin. So the things that are built into the system and continue to go on, continue to put us at risk and impact our health outcomes negatively. So we need to really acknowledge that this is deeply embedded, and acknowledge as medical providers that we've been educated in a system that has told us these things as factual, right? I love that there are some Black OBGYN, female OBGYN that are my heroes that talk about being reformed OBGYNs. They say, I had to realize that I had come through this educational system that had lied to me, and I now have to unlearn those things and relearn the truths from people and from my surroundings, so that I can really examine my own belief system, examine my biases, and be brave enough to be transparent about the fact that, yes, I have come through this racist system, but I have the courage now to re-examine it and see it for what it is, and then move forward. It seems like, really difficult as one person sometime, but I read about a medical student in California who was able to convince her medical system to change one of these, to discontinue using one of these tests with this algorithm, this race algorithm that went into it. Another one that Simone might be familiar with is there's a VBAC calculator. There's VBAC is vaginal birth after previous C-section, and it was what happened was that it systematically predicted lower likelihood of success if the birthing person was African American or Hispanic. And it only was 2 years ago that the NIH advised physicians to discontinue use of this. So again, it is continuing to be an issue that we really need to examine everything that we're taught and that has been taught through the system and re-examine it with a different lens so that we can move forward.
I think, when I think about dismantling sort of racist healthcare practice, it's in many ways about dismantling the comfortable stories we've told ourselves about our work. It's about entering this space of discomfort and examining how, exactly like Linda's talking about, like these social structures shape our actions, our motives, our perspectives. And it's about having courageous and difficult conversations like these. And I think all the time about, the emphasis of medicine is to first do no harm, right? And so if that's the case, then we really need to contend with medicine's history of systemic racism, and also then redefine how we understand health and safety, especially for survivors. So for me, I think we need like a straight up truth and reconciliation process in the medical system, right? Where parties that have been harmed and who have caused harm are able to share their experiences and revise these like ahistorical narratives so that they reflect truth, and we can seek justice in the form of reconciliation, reparations, or some form of resolution. And I will talk about this a little bit later, but this is where that transformative or even healing justice piece comes in, right? And I think sometimes I'm like, oh, Simone, like this is just wild. Like this is never going to happen. And I was doing a little research, and I actually found out that last year, I think it was, the American Medical Association actually put together a task force to begin this process, to work with this restorative justice approach to promoting truth, reconciliation, and healing in the medical field, which I think is incredible. And I don't think enough people are talking about that. And so, we can't move forward until we are ready to grapple with where we've been and like how we got here.
And really understand that race is, that embrace the idea that race is a social construct.
Yes.
And it's a social construct that was established to develop a social hierarchy, right? There's an image that we're going to put up at the end of this segment, which are some more empowering images of when we think about J. Marion Sims. I won't say he's not the father of gynecology, I'm sorry. But when we talk about J. Marion Sims, and we have these really negative images, but to reclaim our stories by developing new images. These are images that are brought forth by a sculptor, Michelle Browder, from Montgomery, Alabama. And she has two images that we're going to share. One is to reimagine the situation where J. Marion Sims was the person being experimented on, and the enslaved women were standing around watching. And the other is to lift up Betsy, Arnica, and Lucy as the mothers of gynecology and and she has developed these, as a sculptor, she's developed these very powerful images of these enslaved women, and they are truly the mothers of gynecology, and they're the people that should be uplifted.
Can I just add one little thing, just because this is all making me think that like the historical context, like we said before, right, like needed before we can even take one step forward. I also want to uplift, and I would be ashamed of myself if I didn't, that this type of dehumanization, right? Because that's what it is. It's thinking like, oh, in order for us to continue the system under this capitalist structure, right, we need to dehumanize folks so we don't blink an eye. For example, the lack of anesthesia, that is occurring present day in Palestine. We're witnessing, right, a genocide of people. We're witnessing men, women, and children undergoing surgeries without anesthesia. And so this isn't like, oh, let's look back and like that happened so long ago. It would never, it is currently happening, being funded. So like, I just wanted to uplift that of like this, sometimes it's kind of like when you see pictures of MLK and they're black and white, just to like trick the mind to think this was so long ago, and yet it was not, right? When you see them in like color, you're like, oh yeah, because that existed. It wasn't that far along.
I don't even know how I could possibly follow up something like that. Thank you all so much. Simone, you said something about us having to reimagine and redefine what health and safety actually is. And I was wondering if y'all would permit me, if I can put y'all a little bit on the spot to just get a sense from each of you, what would be your redefinition of health and safety?
So for me, and I'll get into this a little bit later too, but transforming a system, applying transformative justice to this particular kind of system requires us to envision a completely different world without health inequities, where survivors feel safe receiving care, where racial disparities in maternal and reproductive health outcomes are not a thing, and where survivors are not re-traumatized by the very systems that are meant to be healing. And that, I think, would be my short version of what it could be.
So I guess when I think of it, I think of, so I'm a midwife forever, right? So since the year 1 or 2. And I think the midwifery belief about health is one that I would kind of hold up, because we really believe that the human body knows how to take care of itself, right? And that people know their own bodies, and we have a trust in the process. So for the health of birthing people and the birthing process, we trust the process, we trust it. And we see our role as helping to potentiate what is natural. And that's kind of the health, rather than looking at the whole birth process as an illness to be managed, which is like the medical model. So really uplifting the natural pieces of health and helping people to potentiate their what they already have very often, their own ability to protect their own health and improve their own health.
I would love for all of us to go beyond what we have been told that health is. Access to food is health, right? Living in a trauma-informed community is health. Access to transportation is health. Going for a run and not thinking you could be murdered at any moment by police or anyone else's health, right? Like all of those things are health. So that's I don't even think it's revolutionary, but I invite everyone to maybe meet me at what I think is the basics of it, right? And I think all of us have that same idea of like, health is just all encompassing. Not to be the difficult one, but I myself, both individually and as a trauma therapist, have always struggled with the word safety, because it's so like personal and like depends on your own, right? Like when I talk to survivors and I'm like, part of the work is you tell me like, or you try to feel what feels safe in your body. How's your body telling you it's like not safe or versus safe? And also the weaponization of the word safety by others who are uncomfortable with things, right? So like, and that comes up a lot for me of like, you're not unsafe, you're uncomfortable, and I welcome you to sit there. And so I've been loving the word brave spaces and kind spaces and like all of that in terms of healing. I think maybe that's a new theme in our group of like, what does healing look like? Because I'm trying to fight against this weaponization of safety and everyone having to feel comfortable all the time, when that is not the case. For true liberation of everyone, right? Like a lot of people are going to feel real uncomfortable. And I think that's great. And I think that's a beautiful space to be too.
Whew, Benny, my friend, like, I mean, all of y'all, seriously. Across the country, right? we've seen these attacks on access to reproductive health care with the dangerous rise of like these abortion bans, restrictions on access to contraceptives, and, the funding for like very important resources like Planned Parenthood and sexual health clinics being slashed. We know that these attacks on reproductive justice disproportionately impact BIPOC communities, or as I like to say, people from communities of the global majority.
Exactly.
Who are more, Linda, I see you like that one too. Face barriers in accessing healthcare, as well as experiencing higher rates of sexual violence, poor reproductive healthcare outcomes, including higher rates of maternal mortality. Understanding the impacts of structural racism, how can we do better to support survivors in navigating the healthcare system? And how do we address these disparities in reproductive health outcomes? And how can a transformative justice framework be used to promote change and healing?
My favorite thing to talk about, and I will try to do it, and I have a lot of ideas, and I will try to do it in a way that, doesn't keep us here till midnight. But, I've been thinking about this a lot, and I do have like some actual concrete ideas that are deeply connected to transformative justice. But first, I want to acknowledge that, it's only actually because of the work of survivors that we can even sit here and have these conversations about what trauma-informed care, what survivor-centered care is, right? They organized, they advocated, they demanded that their experience be taken seriously. It's survivors who's raised awareness about their needs, about their rights in healthcare and, other settings as well. And so at the base level, we have to keep doing that, right? Like listening and believing survivors. So I just kind of want to sort of ground us and start us there. And to your point, we've all heard the stories about women and birthing people not being listened to, whether that's in the birthing room, annual well visit, emergency room. And we know it is clear the impact that that has on reproductive and maternal health outcomes. And so we need to really be taking into consideration what clients want and needs, especially survivors. For example, there's this research out there about birth trauma, right? And researchers found that it's not necessarily the method of delivery, right? It's not whether the baby was born vaginally or surgically or at home or in the birth center or in the hospital that results in birth trauma. It's the way the person was treated. Were they involved in the decision-making process? Did they have a voice? Was that voice listened to, right? And so it starts there, right? Just, and it seems so basic, but it's just listening. It's just communicating. It's just taking the time to build relationships and listen to people. As birth workers, and, Linda knows this too, like we've been talking about this stuff for decades. We've been trying to raise awareness about the harmful practices that we are standing in the room and witnessing. And I have like full body chills talking about it because the things that we have seen, y'all didn't believe. People did not believe us. And now, it may not be a huge platform, but there is a platform. And so thinking about this, I've come to this place where I'm now obsessed with sort of like storytelling. And what I've found actually is called narrative medicine, right? And so narrative medicine is really committed to honoring the stories that are shared between providers and patients. And it seeks to understand not only, again, like those individual narratives, but sort of like how we started talking about the structural context and the environments in which these stories are received and told. It looks at the ways that storytelling can be effective in healing and transforming healthcare systems that are essentially broken. I think right now it sort of exists in this like scholarly and academic endeavor. But what we need to do is sort of take it out of that academic space and bring it into practice. And so what that looks like is bringing survivors, bringing community members into spaces to, again, have open and courageous and honest conversations about their experiences navigating their healthcare. And I think also in the spirit of true restorative and transformative justice, it also gives the medical professionals a space to share what it's like for them working in these systems and the barriers they face, right? And so it works to build empathy and it connects practitioners to a clinical practice that's even more emotional and more empathetic. And I think, again, sort of Benny, to your point, the storytelling piece really does work to address the dehumanization process that happens within the healthcare system, right? There is a person behind the chart, behind the data, even behind the white coat. And we know, yes, data matters, research matters, but so do people's voices. And so then like I'm getting really into this and I'm like, oh, storytelling and narrative medicine. And then, every day I'm doing all this research and I came across abolition medicine. And so this is really where I'm focusing my work right now. And it's very deeply tied to transformative justice. So abolition medicine is the idea that our healthcare system actually has a moral, ethical, and professional obligation to use its social powers to interrogate and disrupt systems with a history of harming people. And so when I think about abolition medicine and even reproductive justice, they both work to sort of push medical systems towards a focus on these structural factors that impede bodily autonomy and create all the barriers that we've been talking about today in terms of accessing and benefiting from sexual and reproductive health services. It works to question the power and the structures and systems that enable violence and create racial health inequities. And especially, and I think why I love this so much is because there's a critical focus on understanding the impact on those who've been historically and systemically marginalized. And like we talked about, it really helps to build this sort of abolitionist future for healthcare through this lens of storytelling or narrative medicine. And I know it kind of seems like a new framing, but it's been happening all along. And I think it's really relevant to our conversation today because it emphasizes and amplifies the experiences of marginalization and survivorhood. And then to respond to sort of the piece on transformative justice, I think, narrative medicine, abolition medicine are deeply tied into this, but I do also think it's important to say that oftentimes transformative justice and restorative justice sort of get attached to one another and they're a little bit different, right? And I think depending on sort of what our ultimate goals are, restorative justice may be a little bit more applicable to the medical system because transformative justice is really focused on the work that's being done outside the system, within the community. And so in either case, like there's still this space to bring in this piece around storytelling and community circles and about sitting with folks and sharing experiences. But if we really want to be talking about transformative justice, then we have to be willing to do the hard work of replacing a system that's built on white supremacist, capitalist, heteropatriarchy with a whole new healthcare model. But my question, and I'm not looking for answers today, because I think this is a place where we need to continue to have these courageous conversations, is, do we see our current system behaving in a way that's not oppressive or discriminatory or harmful to survivors and other marginalized folks? Is this current system capable of centering individual and community needs over systems, policies, procedures, and profits? And are we ready to grapple with what it is about our healthcare system that is creating so much harm? And again, not just harm to consumers and clients and patients, but, I'm thinking of overworked, underpaid, unsupported staff and employees too, right? And so I think this is, I think what narrative medicine and storytelling and abolition medicine encourage us to do is to be in these conversations like we are right now, to begin to figure out what exactly do we mean and what is our ultimate goal.
That's amazing. As a storyteller, and one that used storytelling as, again, our word of healing, I completely love that. And I hadn't heard of abolitionist medicine, so I'm going to myself look that up. There is one thing I just wanted to uplift very, very quickly. And you mentioned it, Ari, in your question of abortion bans. And as an abortion storyteller, as someone who's involved in the DC Abortion Fund and collaborated with New Jersey Abortion Access Fund, I would be remiss if I didn't uplift what has been happening, and just wanted to say, like, a lot of folks joined us, and I love this, after Roe v. Wade was overturned, and they're like, oh, now this has begun. And just uplifting as our theme for the day, it began many, many moons ago. Like, this was way before Roe v. Wade. Roe v. Wade was a law. And again, right, we've discussed what laws were built to do, what these systems were built to do for, like, Black folks, poor folks, Indigenous folks, trans folks. There was never true access. ever, even with Roe v. Wade in place, ever true access. So I wanted to uplift that because I don't know if anyone follows Alok, they should, they're a performance artist, poet, and they really speak about how policies and laws, sure, are great, they can protect folks, but we really need to change hearts and minds. And they use the example of South Africa after the apartheid ended. There were like probably in the world pretty progressive with their LGBTQIA plus policies. Like, yet the amount of hate crimes that occurred were still like just astounding. And so what they studied was like, we have these quote progressive policies and laws, and yet people are still harming people, right? And so I bring that up all of to say, like, we also, maybe through storytelling, maybe through courageous conversations, that's what we need to be doing. Because I think, and what was proven in like reproductive justice history, is community is what has always been there for us and what will continue to be there for us. And we need to ask, how am I being a better community member right now?
In the interest of time, Benny, I will just jump to our next question because we have a couple more. So Benny, this one's directly for you. Survivors of sexual assault, they oftentimes seek out medical health support and counseling to navigate and heal from their trauma. Acknowledging the impacts of systems of oppression, what are some common pitfalls for therapists when it comes to engaging in trauma therapy through a decolonizing and politically aware lens? And how can mental health practitioners better implement decolonized trauma-informed care?
Thank you for that. And I'm excited. Like Simone said, I think Linda said as well, I may speak really fast and jump around, so please feel free to ask me to clarify anything. I think one of the biggest pitfalls is thinking that trauma is not political. Trauma is political, period. Right? Mental health is political, period. And even just listening to our conversation so far, we have proven that. It's so political. And I think for a lot of therapists, whether they're trauma therapists, psychologists, however they identify, they think, oh, that is not my place. That is not my job. I am here to do, quote, this service, and I'm piecing out. I don't need to bring anything up. And in my own definition of what ethics is, I believe that is unethical, right? So one example is, as a trauma therapist, and I do identify that way, when I do work with survivors of sexual violence, but I'm going to focus on survivors of sexual violence, we talk about emotions a lot. We love talking about feelings, right? And I do that with every single survivor. However, when I'm working with maybe a survivor who is a woman, I would be remiss if I didn't give the context, okay, let's talk about, let's say, anger in the context of being a woman and how those two may be historically, like by our culture, potentially what can that produce for you when you're trying to engage with your anger or process your anger, right? Furthermore, I would be remiss if I'm working with a Black woman who is a survivor and we're talking about anger and I'm not bringing up and creating that space to talk about, okay, let's talk about historically these really messed up stereotypes about Black women and anger. And also, is anger comfortable for you, right? Like that wouldn't even make sense for the work for me to not facilitate that conversation or invite that in, right? Like it would just be kind of weird to have no better language. Like if I'm working with a survivor who is trans and I'm not talking about transphobia, like how is that going to work? How does that make sense? If I'm working with undocumented survivor and I'm not talking about xenophobia, right? And the dehumanization and the racist systems that these people and survivors are like in, how is that actually doing the work? Like we need to be actively bring this into spaces, or otherwise we're replicating exactly the systems we've been having these conversations for an hour now. Like we're replicating like further oppression, because if we're not creating that space and having these conversations, what we're inherently saying is the problem is you. That's what we're communicating, whether we use those words or it's just by our actions, we're saying it's you. We're saying, oh, you're hypervigilant. That's weird. It's because, no, maybe you have every single right to be hypervigilant. I don't even like that word. Every right to look over your shoulder because you do not feel safe in this world. And maybe it's actually really, really smart for you not to feel safe in this world. And maybe for me to be like, no, it's safe, is actually really harmful to you because it's not, and I cannot guarantee that any place is safe for you, right? Like, that's what I mean. Like, that's what we're communicating. And I know at the beginning I had mentioned like just certain words that are inherent sometimes to these fields, like non-compliance, right? Or even mental illness. I once saw someone through a decolonial lens use spirit wound, and that has forever stayed with me instead of like mental illness, spirit wound. I love that because our language does matter, how we communicate. And I don't mean necessarily to the person, but also who we are as people, because I think one way for all therapists, mental health professionals, humans, is to ask ourselves, how am I in solidarity? Right? So again, if I'm working with a survivor of sexual violence, I have to ask, how am I in solidarity with you? How am I actively trying to dismantle rape culture? How am I actively engaging in bystander intervention when someone says a rape joke? How am I actively trying to dismantle misogyny? How am I actively trying to dismantle racism? Because we will never end sexual violence until we dismantle all of the systems of oppression, right? How am I actively trying to dismantle transphobia? Like, how am I actively trying to decriminalize poverty? Right? Like, until we can say like, okay, this is how I'm in solidarity with you, we're never gonna actually build that relationship that, again, I've mentioned my complications with the word safe, but build a safe or brave space with someone. And I think that's the biggest thing I would like recommend to all folks, especially in this field, is one, like asking those questions for yourself. Like, if I want to work with survivors, then I better be examining how I'm engaging in this society and our world and are an ally, right? Whether I'm a survivor or not, like I need to be asking myself that. In more like maybe practical ways, I think we can always be so creative. Like, for example, when we look at notes, which is everyone's like most hated word as a therapist or like about a professional writing notes, I've seen this movement of people writing notes with patients or clients. Be like, hey, like, how about we sit it for the last 5 minutes and I tell you maybe what I want to put in there. How is that landing for you? Or what would you like in here to make sure either it's me or another person to see? What word would you like? Maybe if I say a word and you're like, oh, I don't like that. Okay, what other word can describe what we just spoke about? What next steps are? A collaborative, I think Linda spoke about this a lot, right? A collaborative approach to that. And yet sometimes we get stuck in this like, oh no, that's, even though that's not unethical, that's not illegal, that's not any, like, that's just a different way to do things. We think, no, that's not the right way. I wasn't taught that. That's not right. Like, and I think we've all had the conversation of, okay, well, I almost said a bad word. Okay, let's put that aside, what you learned versus what are we trying to do here, right? So a collaborative process on top of, we've talked a lot about language and just being aware of the language we're using. But something I wanted to uplift, which I've been thinking about, is this pathologizing of people, of experiences. And we see that present day. The pathologizing, for example, as in genocide is actively occurring. We're pathologizing people's grief and anger and rage as if there's something wrong with that, as if it isn't like exactly how their brain and bodies, I don't use this word, but should be reacting, like how they are wired to react to seeing that much trauma and pain and harm caused upon human beings, right? And I recently, as I was, trying to think about what I wanted to say today and what I wanted to uplift, I came across a term. I don't know if anyone's heard of it. At least my ignorance did not allow me to learn this until a couple of weeks ago. Drapetomania, which was a term, I see someone nodding, a term coined in 1851 by a, I'm going to put it in quotes, I don't know if that's rude, physician. And it essentially is referring to the fact that enslaved folks wanted to seek freedom. And it pathologized the fact that enslaved people would try and run away to seek their own freedom as a disorder, as like a medical disorder, a sickle. And I was like, this has actually not changed, right? Like right now we're like, oh, well, that was 1851. Look at the DSM, right? Like look at this. Like we have paranoia in there. We have hypervigilance in there. We have ADHD. And to be honest, if we break all those down, we can come back to like, yeah, trauma based off systems of oppression. That is people reacting so correctly to being constantly oppressed for their lives every single day. And we're like, no, this is actually like, this is not okay. You can't function. You can't go to work. Okay, how long? Maybe I'll just put depression on the piece of paper. Like, why? Because I'm not contributing to this like capitalist society because of all these systems that are working against me, right? So like, this is what I mean of we need to commit to solidarity and pushing back. I can share personally, I do not diagnose. And I say that upfront. And it's okay if people are like, then maybe you're not the right therapist or person to work. That's completely okay. I do share why. I share I do not diagnose, and I do explain and create that space. My only caveat is like, if you need something for your insurance, I'm going to uplift that happens. For people to get reimbursed, they need a diagnosis. For people to get their money and access like mental health in a diagnosis, that is the only reason. And that's a whole other conversation I have with folks of like, okay, if you're telling me you need this to get your money, we will do this. And let's have a conversation of like the boundaries around that and what that means or what that doesn't mean, what this label means or may not mean for you, right? So like, how are we showing up, right? So I'll pause there. I can keep going, but I also do want to make space if people also want to jump in with their own expertise.
Thank you so much, Benny. What I think I might do is, because I think we're at time, I'd love to just pose the last question, but if folks would like to address the last question, feel free, you can please respond to that. Or if there's anything else that has come up for you, anything that's kind of on your heart that you want to share, also please use that time in that way. But I just want to also put my last question out here for folks as well. So looking forward, how can healthcare systems and institutions work towards creating more comprehensive and survivor-centered approaches to addressing sexual violence within healthcare settings? So I'll turn this over to y'all.
I'd just like to pick up on what Benny said about writing notes in a collaborative way and talk about the electronic medical record a little bit as a way we're going again down a very, I'll use the word scary because for lack of a better word, path. It was supposed to be this thing that was going to make people's lives easier, and it's really, everybody is talking about it's not, it's making it worse. And it's talking about dehumanizing and depersonalizing when you're in a room with a client or a patient and what you're looking at is the computer rather than at the patient or the client and connecting with them. It's really another barrier to developing these real good relationships. And I was in a webinar a couple of days ago when we were talking about obesity, and that's a whole nother thing. I would take another whole area of how that's been weaponized really for people. But talking about one of the factors of the electronic medical record that was supposed to improve communication, but when there are certain words that are you can't exclude them from the medical record, right? So when people go into their patient portal and they see what's been put in about them, that can be really a re-traumatizing experience for people because they see words that are very activating because they're not words that you have to put them in because those are the way these systems are put up. So when we look at these, talk about how things have been developed in these oppressive ways, and then the continuation of it with technology, we need to really be vigilant about what direction we're going in, because that's not the right direction. That's just my piece about the electronic medical record. I had to get that in. Sorry.
I can, I just want to uplift again, sort of this idea of narrative and abolitionist medicine, because I think it really does, and I truly believe this, it holds a lot of potential for healthcare providers to develop a deeper understanding of clients' needs, and also like to tap into the community. I didn't really get into that so much, but this is a big part of it too. It's like tapping into the work, the activism, and the knowledge in the community as a part of the healthcare system, not as separate. And I think this could really start to create a paradigm shift where survivors and communities are centered and they're able to participate in the process, like we've been talking about, in an intentional way that's not extractive, that is, based in affiliation and respect. But I just sort of like the last thing I want to say again, and I promise I will end, is that transformation is not the same as change, right? And so if we're talking about transforming, we're talking about altering the way we are to create something that's not currently possible in our reality. And that's that transformative justice piece. Change, of course, just means improving something that's already possible or in existence. So my question to folks here and watching this is, are we looking to reform or are we looking to reconstruct? But I think at the end of the day, if our goal is to center the experience of survivors, we need to be looking more intentionally at examples of community care as healthcare. Throughout history, communities have found ways to heal and care for one another outside of institutional structures through mobilizing resistance, through mutual aid, through collective care networks that came about in response to organized abandonment from systems like the medical industrial complex. And so I think the last thing I want to say is that when we recognize that our well-being is contingent on one another, and the health and survival if we realize that our well-being is contingent on one another and that health and survival rely on solidarity and collectivizing care on a local level, then I really, really believe that communities and survivors can thrive.
Just a +1 to collective care versus just purely self-care. Again, what are we communicating to people? That it's only up to you and it's your fault and it's your problem. So just a +1 to collective care. And again, to the solidarity, just a reminder for people, no matter your field, whether it's this healthcare field or anything, in your everyday lives, you have the power to engage in community care, to engage in transforming spaces. Again, right, because all systems of oppression are connected, I think sometimes that can feel overwhelming, but what that also means, if you're pulling at one thread, you are working toward the other threads. So engaging in anything you can, I think, is really powerful as well.
And I just kind of like to say that, I love what you said, Simone, about transforming. I think what we've been doing is putting Band-Aids, right, on the holes in the blanket, and what we need to do is reweave it.
I love that analogy. That was brilliant. I think for me, the things that I'm hearing that have really stood out to me are, how am I actually showing up in solidarity? The idea of narrative. As a lover of stories and storytelling, I think it's one of the most impactful tools for revolution. And just this idea of like, how do we reweave this blanket instead of like just patching up these holes with Band-Aids that not only are just covering up the problem, but they're going to fall off themselves. I can't thank y'all enough. Let me tell y'all, I no shade to the other panels, but I think we're the best panel right now. I think we got this. Like, this was so enriching. This was so wonderful. And I just am so grateful to all of you for being here and sharing so generously. Thank you all so much.
Thank you so much.
Thank you.